Common musculoskeletal problems. Test success tip. When conducting an orthopedic exam, assess the entire person, not just the musculoskeletal problem. You know what this reminds me of? What we talk about with derm is that with derm, it's tempting to just look at where the problem is on the skin and call it a day. Same thing with orthopedics, because what you might miss is the orthopedic manifestation of a systemic problem. So let's take a look. First of all, with orthopedic assessment tips, is the patient otherwise well? When otherwise well, likely has a condition limited to the bones and or joints such as osteoarthritis, osteoporosis, others. Now, that doesn't mean to be dismissive of these problems, because these are, like, just using these examples, OA and osteoporosis, these are major threats to a person's overall health. But these are diagnoses that do not affect the entire body. Does a patient have systemic symptoms and signs? When systemically ill, like fever, involuntary weight loss, anemia of chronic disease, rash, joint swelling, etc., the patient often has the orthopedic manifestation of a systemic disease, such as rheumatoid arthritis, systemic lupus, polymyalgia rheumatica, and others. What's the patient's risk factor or predisposing conditions to a given orthopedic condition? Are there acute factors, i.e., a history of trauma, sudden change in physical activity, age, gender, overweight, obesity, a history of currently existing autoimmune problems? Remember, autoimmune disorders like to hang out with one another. What's the person's profession, sports, repetitive movements, medication use, and the like. And let me give you a couple of hints on this. First, patient, 55-year-old man, BMI of 38, works as a roofer, physically active work. He's going to be on his knees on the roof on a regular basis, bilateral knee pain, generally worsening over the last 3 years, few physical exam findings. You want to consider the diagnosis of osteoarthritis. With OA, generally there are very few physical exam findings. Contrast that to a 31-year-old woman with a BMI of 21, works in data entry, has type 1 diabetes. Keep in mind that's an autoimmune disease, complains of joint ache and stiffness in the morning, unexplained weight loss and fatigue. You want to consider rheumatoid arthritis in that woman. Why would it be? Because she's younger, she's female, healthy BMI, works in data entry. There's nothing there to make us think, like with the roofer who's doing repetitive physical activity, there's nothing in the comment of her being in data entry, except maybe her hands could be involved. But the unexplained weight loss, the fatigue, this is classic presentation of RA. Also, the classic patient who develops RA. Now let's move on and take a look at this next question, assessment diagnosis question. Question 1. Joe is a 54-year-old man with COPD who presents with an 18-hour history of sudden onset monoarticular pain consistent with acute gouty arthritis. This is a condition you might be simply more accustomed to hearing called gout or gout flare, gout attack, but monoarticular. What does that mean? It's affecting literally one joint. So with this, what are they asking us? They're asking us, where is Joe's gout most likely to present clinically? And he denies recent or remote trauma to the area, has had similar episodes in the past. Joe's taken acetaminophen 1 gram times 2 doses in the last 12 hours with little effect. He admits to drinking about 2 to 3 cans of beer each night, and both his brothers have gout. What do we have here? We're being told he has gout, has a strong family history of gout. He drinks alcohol on a regular basis. Tylenol's not helping it, which I'm not surprised. Tylenol doesn't touch the pain that goes with gout. And now what it asks us to do is the most likely presentation of the condition. You are being tested as an entry-level NP. You're going to be tested on classic presentation of disease. But in order to answer a question like this, you need to know some anatomic markers and where the disease is most likely to occur. Would it be A, swelling at the third distal interphalangeal joints? Well, where are the interphalangeals? In the hand. Is that where we see gout? No. Would it be B, redness at the first metatarsal phalangeal joint? In other words, at the base of the great toe. That's probably going to be our right answer, but let's go the rest of the way. C, a firm white 4 millimeter nodular auricular lesion, so on the external ear, or D, a fusion in the right knee. So what are we talking about? B, of course, is the correct answer, is redness at the first metatarsal phalangeal joint. By the way, this is an illustration drawn in the 1800s by a cartoonist who had gout himself. Do you get an idea of what it feels like to have an attack of gout? It's horrifically painful. The image that you saw with the auricular lesion, that's called tophi or tophaceous gout, and that's the deposit of the urate crystals in the soft tissue. It is seen, it's not that common. Let's just take a moment and reflect. Where are the two most common places in a joint for a person to have gout? One is here at the base of the great toe, the other is in the wrist. Why those two joints and not others? Because what's in the joint during an attack of gout is urate crystals. That part of the body needs to be thermally cool for the crystals to precipitate out. And if you compare like the wrist to someplace like, let's say, the hip, the wrist is cooler from a temperature viewpoint than the hip. Why? The hip's buried deeper in the body. The surrounding tissue keeps it warm. The base of the great toe is cooler than, let's say, the shoulder, because what do you need? You need that cool part of the body to precipitate out the crystals. Why is it then that tophi occur in the auricle, the external ear? Again, it's a part of the body that can be thermally cool. This is a mesh question looking at intervention per evidence-based practice. You can see the image here that gives you an idea of what gout can look like. Question 2, which of the following would be a preferred medication in treating Joe's episode of acute gouty arthritis? Would it be A, high-dose aspirin, B, naproxen sodium, brand name Aleve, C, Uloric, D, oxycodone? So let's take a look at D, oxycodone. Well, trying to avoid the use of opioids for acute painful conditions, sometimes it is necessary. When looking at option C, Uloric, that's a med to prevent gout, not treat it acutely. The best answer here is naproxen sodium, high dose NSAID use. And what you have to know is, in order to treat gout, the difference between treatment therapy and controller therapy. And the NSAIDs are considered part of the treatment for a gout, not controller therapy. What you'll notice on this x-ray is you could see a lot of soft tissue swelling around the joint at the base of the great toe. That's an anticipated finding during an attack of gout. With gout therapy, you need to keep in mind when and if to start preventive therapy. And if you ever wonder why patients are so uncomfortable with gout, what I'd like you to do is take a look at the image on the screen here. What you're looking at are the urate crystals that will settle into the joint in a person having an attack of gout. I look at this and I say, to me, they look like little slivers of glass, but that's why people are so uncomfortable. Question 3. Joe mentions that he heard there are medicines to prevent a gout attack. We also know from his history he's had gout before. When should Joe's plan of care include initiation of preventive therapy for gout? A, within 24 hours of symptom onset, i.e., in the midst of a gout episode. B, once the acute flare symptoms have resolved. C, about 6 months after following treatment for acute gouty attack. D, at the onset of the next gout flare. You might look at this and say, oh, that's kind of a complicated question, but this would be anticipated to be part of your walking around information. So, when should Joe initiate preventive therapy for gout? It should be 6 months following the treatment of an acute gouty attack. Sooner, it can actually be problematic and result in more symptoms. What's generally the first line drug? It will be allopurinol. This is a drug that's been around forever, low cost, pretty well tolerated. And are there other medications available to treat gout? Oh, there are many, but generally start with allopurinol. Question 4. When advising Joe on dietary modifications to prevent a future gouty episode, the NP recommends avoiding which of the following? Would it be A, brown rice, B, peanut butter, C, organ meats, D, squash? And the correct answer here will be C, organ meats, because organ meats are an example of purine-rich foods. And what's purine? It is a chemical compound that forms uric acid when metabolized. What are some of the points to consider in the care of the person with gout? First, look at the risk factors: obesity, diabetes, family history of gout, which is what Joe had, the use of select meds like thiazide, diuretics, niacin, aspirin, alcohol use, particularly daily alcohol use, purine-rich diet, lots of organ meats, forms of seafood, including sardines and anchovies, spinach and oatmeal. I always look at this and I say, so this is the one thing on earth that oatmeal is harmful, because oatmeal tends to be something we think of being healthier food. Chronic kidney disease and renal failure. Why with CKD would a person suddenly develop perhaps first episode of gout? Because with CKD, offloading urate/uric acid is not as efficient as it once was. Presentation, I think most of you are aware of this. Acute onset severe joint pain most commonly will be the base of the great toe. Causes. Interestingly enough, with gout, only about 10% have uric acid overproduction. 90% will have urate under excretion, which is then made worse with risk factors. With treatment, what you want to do with a acute gout flare, get the NSAID on board within 24 hours of the onset of action. Most of the time, the patients will present coming in very, very rapidly after the onset of gout because it's so acutely painful, particularly with the first episode. High dose NSAIDs are usually what are used. Other options include oral corticosteroids or oral colchicine. Colchicine, not so much used these days because it's a little tough on the gut, but they are all appropriate first line options for the treatment of acute gout, and certain combinations can be employed for severe and or refractory cases. If currently taking pharmacologic urate lowering therapy, this should be continued without interruption during an acute gout attack. And then a xanthine oxidase inhibitor, such as allopurinol, Uloric, those are considered to be the first line pharmacologic therapy to prevent an episode of gout. There are other therapies to prevent gout. that are much more expensive, including some that are given subparenterally. But on the other hand, for the purposes of the boards, think allopurinol will be what you are most likely tested on. Always start at 6 months after an episode of gout. Serum urate levels should be lowered sufficiently to durably improve signs and symptoms of gout, generally with a target of the urate level, serum urate level being less than 6 at minimum, and sometimes you need to bring it down less than 5. And then combination therapy can be used if you're unable to get that urate level below 5, in particular, and the patient is still symptomatic, breaking through with flares of gout. This next part, question 5, this is going to be a quick drill that we're going to do and look at the sign or test with the relevant condition. And this often does come up on boards. What I've done with this exercise, I certainly have not gone into every orthopedic sign or orthopedic test that exists, not by a long shot. But what I've done is hit the most commonly encountered. These would be assessment questions, and what they'll allow you to do is move on to the differential diagnosis. So let's take a look at McMurray, Teller tilt, Sperling, Tinel sign, Lachman's test, straight leg raise, drop arm test, and Finkelstein's test. And as we have done with almost every other condition we've looked at, what we're going to do is say, is the patient being presented at risk for a certain orthopedic problem? And if the answer to that is yes, then what test would be associated with this? So this is a 17-year-old football player with knee pain after a twisting type injury, has reduced range of motion, and report the feeling of the knee locking. What would that be? That's a meniscal tear. And what would the test be that we do for a meniscal tear? That's a classic presentation of meniscal tear. It's going to be A, the McMurray test. A 15-year-old basketball player with a history of multiple ankle sprains feels ankle rolls inward more easily, and there is ankle pain. What would that be? That's ankle instability, described in the patient scenario. And what would the test be? It's going to be Teller tilt test. My ankle is aching just looking at that image. And a 52-year-old man who constantly uses a soldering iron throughout the day feels numbness, tingling, and weakening in the dominant hand. That is the hand he uses more. And I believe most of you would recognize this as a repetitive motion condition. And that, of course, describes carpal tunnel syndrome. And what would you do? Look for Tinel sign. Whenever you see a patient who appears to have a work-related problem, ask them to show you what they do in their work. And what this gentleman would do is show the following. We'd say, okay, here's a soldering gun. I need to solder 2 places on what comes down the assembly line ahead of me. And sometimes when we're really busy, will use both of my hands because I've trained myself to solder both ends when we're super busy. What is he doing? He's doing repetitive grip motion. And that's how he has developed carpal tunnel syndrome. Carpal tunnel syndrome is not just people who spend a lot of time on a computer laptop. Many other occupations can trigger this. An 18-year-old soccer player experiences sudden knee pain and swelling during changing direction rapidly and heard a popping noise, has reduced range of motion. What does this describe clinically? This describes ACL tear. And what would be the test that would reveal this? And it is going to be option E, the Lachman's test. A 62-year-old with a history of spondylolisthesis and experiences low back pain that radiates to the legs and feet with numbness and muscle weakness. What does that describe? That describes lumbar nerve root compression. That person will have an abnormal straight leg raising test. You can also see that with lumbar radiculopathy. A 32-year-old with neck pain following a motor vehicle accident with tingling and numbness running down the shoulders, arm, and to the thumb. What does that describe? That describes cervical nerve root compression, and the test would be Sperling test. A 14-year-old baseball pitcher complaining of pain and swelling on his throwing arm, clicking sound heard when the arm is raised, pain triggered by raising and lowering the arm. What does that describe? That describes that there could be something wrong with the rotator cuff. And again, pitching, that is a key trigger for a rotator cuff injury. And what would be the correct answer? Then it's drop arm test. A 44-year-old drummer who complains of pain and swelling at the base of the thumb and feels a sticking sensation when trying to move the thumb. And that describes a condition with the most curious name, de Quervain's tenosynovitis. And it literally is right around this region. And again, think of a drummer. Drummer is going to have a drumstick in the hand. Those of you who are musicians are probably cringing with the way that I just said I would hold a drumstick since I don't play drums. But you always have to consider what that would look like. And this is Finkelstein's test. You might, as we went through this, say to yourself, wait a minute. Those were a lot of terms I weren't familiar with, tests that I've heard of, but I'm not sure what they are. That's why you're in this course. You're in this course to build your knowledge base so that when you get a question about one of these, you could call up your knowledge base and answer it correctly. Test success tip: differential diagnosis of a musculoskeletal complaint includes considering whether it is a systemic or localized orthopedic issue. So we're into an assessment differential diagnosis question. Now you'll notice some of the questions that I just went over. A lot of the people were younger. Some were teenagers. Remember, for the AGNPs, your scope of practice starts at age 14. So all of those questions on the teens were fair game for your boards. Now we're talking about an older adult. And we always want to, again, put into our heads, okay, what conditions are more common in older people? And this is an orthopedic condition that is largely seen in older women. Question 6. Ms. Hennigan is a 70-year-old woman with well-controlled hypertension, dyslipidemia, and hypothyroidism. Her current meds include a statin, ACE inhibitor, a thiazide diuretic, and levothyroxine replacement. In other words, why are you given these data? So that what you can say to yourself is, all right, I'm looking at her meds. There's nothing particularly unusual given her underlying health issues. She presents today with the chief complaint of a 2-month history of fatigue and aching sensation, accompanied by morning stiffness in her hips and shoulders. So we're going to stop here for a moment. Hip joints, shoulder joints, large joints. Hands, wrists, ankles, feet, small joints. She has a large joint condition, and that's going to be very helpful on our differential. During this time, she's lost 8 pounds, quote, without even trying. So what's that? Involuntary weight loss, and reports struggling to get dressed, especially when putting on a shirt or pants. Well, if your shoulders really hurt and they felt like they were stiff, I bet you'd have difficulty getting on a shirt or a pair of pants. Involuntary weight loss should automatically make you think this isn't just an older woman with some OA in her shoulders and hips. This is the orthopedic manifestation of a systemic condition. Physical exam reveals full limb strength, decreased active range of motion in the hips and shoulders, cool, smooth joints. So you palpate over the shoulder joints, no redness, no heat, same over the hips, and no excessive muscle tenderness. Multiple systems are involved here, mostly large joints. Laboratory testing includes the following. Her hemoglobin is 10.8, her hematocrit is 32%, MCV is 86, RDW 12.2%. We've looked at a lot of anemias as we've gone through this program, and you do need to keep that in mind, that the information on the exam, once you've answered a couple of cut and dry questions on anemia, anemia could crop up again when we're looking at a person with an orthopedic problem. So she's clearly anemic. Her MCV is 86. Upper limits of normal is around 96. So she's normocytic. And normocytic always means normochromic. RDW 12.2%, telling you new cells, old cells, the exact same size. And her SED rates at 112, upper limits of normal is 20. What do we know here then? Normocytic, normochromic anemia, normal limit RDW in a woman with marked systemic inflammation. The results of her hemogram reveals A, iron deficiency anemia, B, pernicious anemia, C, anemia of chronic disease, D, age-related normative findings. Let's take a look at D as an option. And, there is some evidence as people get older, their H&H might go down a little bit, but that's generally people of very advanced age, not a woman of her age. The other part, I would dismiss normal age-related changes right out of hand because of the degree of her anemia. The other part, we're given all this information about her having a systemic condition going on and that high SED rate. So that goes away. Let's take a look at C, anemia of chronic disease. And that is our best answer and actually our only correct answer there. B, pernicious anemia. What would you expect to find? Macrocytic, normochromic, elevated RDW. And I would expect some kind of a neurological component, numb hands, numb feet, feeling like her mind's not as clear as it should be. If it was iron deficiency, I would expect that on boards, the scenario would not give me all that information about her joint aches and the fatigue and the unexplained weight loss. And on hemogram, she would be microcytic hypochromic, elevated RDW, because as you'll recall, what's the leading cause of iron deficiency anemia in adults? It is chronic low volume blood loss. C, anemia of chronic disease is the best answer. On this, then, we're going to hop over to question 7, differential diagnosis. Ms. Hannigan's clinical presentation is most consistent with A, rheumatoid arthritis, B, fibromyalgia, C, osteoarthritis, D, polymyalgia rheumatica. On the boards, remember, what are they trying to do? They're trying to test your clinical decision making. So here's boards, here's clinical practice. They're joined together like that. Only 2 of these conditions will cause markedly elevated SED rate. And they're options A and options D. Fibromyalgia does not cause the SED rate to go up, nor does osteoarthritis. So we can eliminate those 2. Now what we have to do is say, okay, we've got an older woman. I will tell you, women, a lot more RA than men, right? So that's a possibility. Untreated RA can cause anemia of chronic disease because of the body-wide inflammation. But remember, rheumatoid arthritis, particularly at the time of diagnosis, largely is smaller joints. Think the hands, the wrists, the feet, the ankles. The best answer here is D, polymyalgia rheumatica, because it is more consistently a large joint disease. And Ms. Hannigan has the classic presentation of polymyalgia rheumatica. The most appropriate next step in Ms. Hannigan's plan of care is to A, referral to physical therapy, B, rest and ice to the affected areas. C, initiating a course of systemic corticosteroids. D, prescribing low-dose bisphosphonate therapy. Bisphosphonate would be a drug like alendronate, Fosamax, or something along those lines. So what's the best answer here? Remember, part of the best answer is you want to look consistently for the option that's going to give you the most therapeutic effect. We have 4 different choices here. Option B, rest and ice to the affected area. That is wonderful for acute injury, can actually be helpful for certain other chronic conditions, but it's not really an option in polymyalgia rheumatica. A, refer to physical therapy. Not a bad idea. You might do that. That would help keep her from getting deconditioned. She's an older adult. It hurts to move. Older adults get deconditioned very quickly. C, initiating a course of systemic corticosteroids. Far and away the best answer. Why would that be? Because keep in mind, about 50% of people with polymyalgia rheumatica will also have a component of giant cell arteritis. What do you need to do? You need to get rid of that inflammation. Systemic corticosteroids will do the trick. D, low-dose bisphosphonate therapy. That's treatment of osteoporosis and would not be germane to this particular scenario. C is the best answer, initiating a course of systemic corticosteroids. And in your handout, there is a table on polymyalgia rheumatica. Please include that within your study. Question 9, indicate whether each of the following is consistent with RA, systemic lupus, or both. More common in women, and that's going to be both. An autoimmune disorder, once again, that's going to be both. Classic presentation of fever, joint pain, and a rash in sun-exposed areas, including the face. What will that be? That's going to be systemic lupus. Anemia of chronic disease, common at the time of diagnosis. Again, both. Why? Because they're multi-system inflammatory diseases. Elevation in ESR, in CRP, C-reactive protein, or SED rate. That's going to be both, particularly at the time of diagnosis. Treated with a biologic and or non-biologic DMARDs, disease-modifying anti-rheumatic drugs. That's what DMARD stands for. And what's that going to be? That's going to be both. And can present with subcutaneous nodules. What will that be? And that's going to be rheumatoid arthritis. You can see from going over that quick drill, it's a slightly challenging differential, is it not? It really is. And therefore, what you need to know is, again, keep in mind RA, largely smaller joint disease, and then the systemic lupus, generally you're going to get that face rash with it. And this gives you an idea of the classic, what's often called the butterfly rash that can go over the face. Now, it's usually noted most vividly on the cheeks, but it can spread up to the forehead. And I've had people tell me who didn't do so well on boards. Well, I had a scenario of a woman with facial lesions. So I was thinking of systemic lupus. And I said, okay, that's fine. You can put that in to your differential. But now tell me, were you given any information about joint aches? Were you given any information on anemia of chronic disease? Were you given any information on unintended weight loss? And if the person says no, no, and no to all of those, then get away from lupus. Get away from lupus. Think of something else that could affect the middle of the face, like rosacea, because this is important. When you're looking at this, you have to consider, do you have the orthopedic manifestation of a systemic illness, or do you have the dermatologic manifestation of a systemic illness like you would in particular with both RA and systemic lupus. In the handout, we've included a table for you to add to your study on rheumatoid arthritis versus systemic lupus. Please include that within your study. In your handout, also, Table 5, common causes of knee and other joint pain. Let's switch gears now and take a look at a counseling safety question. Question 10, which of the following is an acceptable team sport for a college-age young adult with a bleeding disorder to participate in? What you have to do is consider this. A person with a bleeding disorder is likely to bruise more easily. If they're cut, they could bleed more easily. Would it be A, lacrosse, B, soccer, C, swimming, D, no team sport is acceptable? What are you looking for here? You're looking for a low impact, low collision sport. There are two ways to approach a question like this. Let's say you've never been exposed to information like this. You could look at this question and go, how the heck am I supposed to know the answer to it? This has really thrown me. I'll never get through the rest of my exam. Or you can go back to analysis and synthesis of the information presented to you and say, okay, deep breath, bleeding disorder. What do we want this person to do? Do we want this person to be banging in to other human beings while they're playing the sport? I don't know a whole lot about sports in general, but I do know with lacrosse and soccer, people bang into each other on a regular basis. I would get rid of those two as options. Swimming, low contact, easy on the joints, correct? Okay. Swimming is the best answer. And looking at option D, this is important on all your exam questions. Watch for questions with all or none statements. Option D says no team sport. Nope, never. Never a team sport. No. All or none statements are seldom correct on boards because we're in a line of work where very few things are all or nothing. What would you say to this college age adult? Oh, you can't join the golf team? No, of course you wouldn't say that. But swimming is often considered to be one of the better forms of exercise for people who have any kind of increased bleeding risk. Test success tip. Low back pain is one of the most common musculoskeletal conditions seen in primary care. It's often referred to as, if you will, the common cold of the orthopedic world because it is what you're going to see. Table 6, I'm going to go over the differential diagnosis of lower back pain. The first I'm going to talk about is lumbar sacral strain. This is the most common musculoskeletal problem you will see in primary care. Etiology is spasm, irritation of the lumbar sacral spine supporting muscles, and will be the most common reason for low back pain. Discomfort characteristics include spasm, ache, stiffness, position, activity, rest typically impacts pain. That's an important part of your differential. What is the patient's most uncomfortable position, most comfortable position? How do they feel walking? And very often, the results of that will help you with the differential because quite often people with lumbar sacral strain will say, I actually feel better when I walk. Okay. I feel worse when I sit for a while. And then if I could get down flat, I feel the best I will feel in any position. On physical exam, paraspinal muscle tenderness and spasm. You look at the lumbar sacral curve, it's straightened, decreased lumbar sacral flexion. Ask the patient to bend over, unable to do that to much of a degree of ROM. This is key in lumbar sacral strain. Neuro exam is normal. Normal neuro exam. No loss of limb strength, no foot numbness. DTR is intact, the whole 9 yards there on the lower extremity neuro exam. How do you treat this? And moderate pain and stiffness can last 1 to 2 weeks. Greater than 90% will completely recover in 1 month. A lot of this with LS strain is talking the patient through it. Very uncomfortable. And, we're all healthcare providers. We've been hauling patient out of bed, helping people get up, that type of thing. I suspect virtually all of us have had at least one episode of this. Some kind of analgesia, generally NSAIDs or acetaminophen. Try to avoid opioids. Encouraging physical conditioning and therapy because limiting physical activity is potentially harmful, leads to deconditioning. Heat or ice as dictated by pain response. I'll often seen people in office with acute lumbar sacral strain, and they'll say, "Oh, I've got a heating pad. I've got a this. I've got a that." It's all heat therapy, and they'll say, "Oh, it's not doing any good." I'll say, "All right, give ice a try. Give it a try." "Oh no, I don't like the idea." I said, "Like, please listen to me. Give ice a try." And then they try ice and they're in a lot less pain. Conversely, I can have somebody that comes in and says, "I've tried ice, it's not helping." I'll say, "Now try heat." Whatever works, whatever works. Skeletal muscle relaxers, usually abbreviated SMRs, can be helpful, but all are sedating and some of them have abuse potential. There's one in particular, brand name Soma, and that's the one with the most amount of street value. And the way I remember this is Soma rhymes with coma because people can get barely buzzed on that drug. Now, what about lumbar radiculopathy? What's the etiology? It's irritation or damage of the neural structures, such as the discs. L4, L5, L5, S1 are the most common sites of disc bulge. And what will the discomfort characteristic be? Sharp, burning, electric shock type sensation. Worse when the patient does anything that increases spinal fluid pressure, thus put more pressure on the nerve root. Often what the person will describe is very severe pain when sneezing, coughing, any kind of straining, like trying to get down to sit on the toilet. That makes it worse. And that just as there are with LS strain, positions of greater comfort and discomfort, but very often this sneeze or cough, they'll say, "Oh, the pain just runs right down my leg," something along those lines. What will you find? You'll find with lumbar radiculopathy, the physical exam will have a lot of common characteristics with lumbar sacral strain. But here's the key. With radiculopathy, you get an altered neuro exam, including the abnormal straight leg test, sensory loss, and altered DTR. So one more time, your differential, lumbar sacral strain, normal neuro exam, lumbar radiculopathy, abnormal neuro exam. And I will tell you, both groups can be equally uncomfortable. Don't go by degree of pain alone. I've seen people with perfectly normal neuro exams, lumbar sacral strain, who are very uncomfortable. What's the intervention with lumbar radiculopathy? Keep this in mind. This is an important piece of information to get to the patient because the patient's pretty miserable. Up to 70% improve within 2 weeks. What are we getting the idea here? With low back pain, time is often your best intervention. And what you need to do is work with the patient to get them as comfortable as possible for these shorter periods of time when their back will be rather painful. Conservative therapy is where we start. Exact same thing we do with lumbar sacral strain. Heat, ice, whatever works the best. Analgesia, skeletal muscle relaxers. Specialty evaluation and intervention is indicated for rapidly evolving defect, persistent neuro defect without resolution after 4 to 6 weeks of conservative therapy. Please do not refer out before that 4 to 6 weeks of conservative therapy because there's a general rule with referring to a specialist. You want to refer a patient to a specialist when the specialist can do something you as a primary care provider cannot do. And if you've got somebody with lumbar radiculopathy who's 3 or 4 days into it, and you could magically get them into neuro within a week or so, what is neuro going to say, or orthopedics going to say? Going to say, chill out for another few weeks. Let's see how you do without particular intervention. About 10 to 15% will eventually require some surgical intervention. When would you refer sooner than the 4 to 6 weeks in that rare person that you'll see with a very rapidly evolving defect? I remember a few years ago, I had a younger woman in her 30s come in with a foot drop, had previous episodes of radiculopathy. She said, this one's much worse. I've never had my foot flap around like this. I looked up her old notes that had noted with her previous episode of radiculopathy that had resolved with conservative treatment, that she did not have foot drop, that she had mildly decreased lower extremity DTRs. On the leg with the foot drop, she had pretty much absent DTRs. And she was having a hard time getting around. This was a woman only in her 30s. I sent her off for referral early on. If I'd seen her with the previous episode, where she came in with only mildly altered neuro exam, I would have gone ahead and done the conservative therapy first. And the conservative therapy had worked a few years earlier than that. This is an important table to include in your study. Remember what nerve root and what reflex goes with it. L4, knee jerk. L5, no reflex. S1, ankle jerk. And remember, what's the most common locations of lumbar radiculopathy pathology? L4, L5, L5, S1. Many patients will have both of those areas involved if they develop lumbar radiculopathy. Now, what about diagnostic imaging and low back pain? Here's what we're going to do. We're going to go to best evidence. No imaging will generally be what we're doing during the conservative therapy. No criteria for immediate imaging of any kind, X-ray, MRI, CT, during the 1 to 2 month trial of standard conservative back pain therapy, particularly in the presence of a normal neuro exam, the absence of acute significant trauma, and low risk for vertebral compression fracture. I'll give you 2 examples from my practice. Same patient. Woman well into her 70s comes in to see me. She's got acute low back pain. She just finished babysitting a very good sized great grandchild, a toddler who she was picking up. She clearly had some lumbar sacral strain, intact DTRs, had iced her back. She felt much better with that. A few days later, she was okay. So we had a precipitating event that I could document, and that she was better with conservative therapy. The other is she came in, the same patient, about a year later. She had been at a family outing, was outside on a patio near a swimming pool. A lot of water had been splashed out of the pool onto the patio. She slipped, fell, landed on her back. She was a woman in her 70s with actually very good bone density given her age. She did end up with an X-ray because the fall, even with decent bone density, I'd be very concerned about vertebral compression fracture, which thankfully she did not have. So same patient, 2 different scenarios. One imaging, one not imaging. MRI, when would you consider this? For signs and symptoms of radiculopathy that persist after a trial of standard conservative therapy in patients who are candidates for surgery or epidural corticosteroid injection, risk factors for or symptoms of spinal stenosis in patients who are candidate for surgery. You really will notice here then there's not a robust recommendation for early MRI. You're going to wait at least 4 to 6 weeks and see how people do. Now, for those of you who are ED providers and you're thinking to yourself, yeah, but what about dissecting abdominal aortic aneurysm? That can cause acute low back pain in older adults. You're absolutely right. Generally, in a person at very high risk for atherosclerotic disease, generally excruciating pain that comes on very quickly. Icing does nothing. There's no position of comfort. You have to always look at the entire scenario of a patient before you go and push the button for dissecting abdominal aortic aneurysm. What I want you to get the thought process with, you're out in the outpatient setting, common diseases occur commonly, and that most patients with low back pain will not have a very serious and potentially life-threatening reason for their low back pain, like dissecting abdominal aortic aneurysm. Let's take a look at a patient here. And whenever particularly you're seeing a woman with back pain, what you have to do is consider, does she have very significant osteoporosis risk? Question 11, you're evaluating Karen, a 48-year-old woman who's a non-smoker and drinks 2 glasses of wine per week. She has long-standing intermittent lumbar sacral strain that she attributes in part to her work, which requires her to be physically active. So all we have here is her age, a little bit about her social habits. 48 years old. How old is the average woman in the United States when she has her last menstrual period? 50 to 51 years of age. Assume then, because of that, that Karen is perimenopausal, but not postmenopausal. And that because she's premenopausal, that reduces her osteoporosis risk. She says she does physically active work. I would like to know a little bit more about that physically active work, but we just have to deal with what we have. Physically active work equals less osteoporosis risk. She's a non-smoker. Tobacco use is a very potent osteoporosis risk, and high alcohol consumption is also a potent osteoporosis risk. She has neither one of those. I'm therefore looking at her as a woman who does not have a particularly high osteoporosis risk. I hear the choruses of yeah, buts, I need to know more about her. Here's part of your job getting through this boards. Look at the data you've been given. Assume they've given you enough to answer the question. But we have to keep in mind all the data presented. Today, she presents with a 2-week history of shooting pain down her right leg and occasionally dragging of the right foot with walking. She denies any recent trauma or precipitating event. Examination reveals abnormal straight leg raising, diminished right patellar reflex, and difficulty performing heel walking. What do we have here on exam? We have an abnormal neuro exam, correct? The other part, this is a report of pain with dragging her foot and the pain shooting down her right leg. That's not all that consistent with lumbar sacral strain. Now, this is key history. She relates, I'm really uncomfortable. This is different than my usual back pain. Always listen to what the patient has to say. And one of the keys here is this is different. So her presentation is most consistent with A, lumbar radiculopathy, B, exacerbation of chronic lumbar sacral strain, C, vertebral fracture risk, or D, spondyloarthropathy. Best answer here, of course, is A, lumbar radiculopathy. What would trip me over from that versus option B, that it's just an exacerbation of her chronic lumbar sacral strain? It is new pain, different than my usual back pain, and the abnormal neuro exam. So this is something different. That's why I would exclude B, exacerbation of chronic lumbar sacral strain, because if it were, what Karen would likely come in and say, I've done it again. This is what my back gets like certain times, that type of thing. C, vertebral compression fracture, there's no trauma history. She's a younger woman. Do I appreciate that 88-year-olds could get a vertebral compression fracture without a history of trauma? Absolutely. She's not 88, she's 48. Spondyloarthropathy usually would be a more long-term scenario, not quick like this, just 2 weeks. The other part is you would likely have other findings with option D. And what we're going to do now is intervention based on evidence-based practice. Question 12, which of the following represents the most appropriate next step in Karen's plan of care? A, advise a 3-day course of bed rest. B, refer to physical therapy. C, order a lumbar sacral MRI. D, obtain a standing lumbar sacral X-ray. Right? So let's start with D and work our way up. Is there any reason to rule in, rule out fracture on Karen? None. Zero. No trauma history. She's not a big osteoporosis risk. So I would eliminate D. What about getting a lumbar sacral MRI? She does have an abnormal neuro exam. And the answer, once again, is no. Conservative therapy for 4 to 6 weeks. Some sources will even say 8 weeks before you go ordering specialized imaging. Would you B, refer her to physical therapy? And that's our best answer. And I've said this a few times earlier in the program, always look for the intervention that is going to give you the most return on your investment. And physical therapy will be very helpful for a few reasons. One, it's going to help prevent deconditioning. Two, also, a lot of times certain exercises can help relieve the discomfort considerably. So would it be A, advise a 3-day course of bed rest? The answer there is no, you would not. Years ago, that's what was advised to people with lumbar radiculopathy. That was then, this is now. What's definitely noticed is that people who do take to bed with lumbar radiculopathy, or for that matter, lumbar sacral strain, get quite deconditioned, and then that perpetuates their discomfort and slows down their recovery. Truth be told, what I would do with her is I'd say, you seem pretty uncomfortable. Let's try ice, skeletal muscle relaxers, analgesia. I'll give you a note for work. Take a few days off. Try to ice that back as much as possible. Get into physical therapy just as soon as possible, and then see how you feel. Table 9, lumbar spinal stenosis, looking at assessment and intervention. What are features on clinical presentation? Older age, 50 years and up, the presence of RA and other autoimmune conditions. Standing discomfort with improvement in symptoms with bending forward is nearly universal. When I say bend forward, I don't mean this, but I mean when the person is standing, just going forward a little bit like that can really help improve symptomatology. Pseudoclaudication, which is leg pain that worsens with activity and improves with rest, commonly found, and bilateral lower extremity numbness and weakness in the majority. What are the diagnostics with lumbar spinal stenosis, and what should you know for boards? First of all, for boards, you should know how to recognize this. That's your job. And for symptoms persisting for more than a month, because in the first month it's conservative therapy, no diagnostics, you could consider X-ray, CT, MRI, EMG, nerve conduction velocity type of imaging. General rule, if you strongly suspect spinal stenosis, then consider getting the MRI and refer to a spine specialist. Conservative therapy, like symptomatic relief, prevention of neurological sequelae, is generally what the therapy is. So you, as a PCP, right off to physical therapy, start NSAIDs, and then if that's unsuccessful, go with epidural corticosteroid therapy. And surgical intervention for decompression surgery is oftentimes considered if the person does not improve with more conservative therapy. This is what lumbar spinal stenosis can look like on CT. You can see where the arrows are, the compression on the spinal cord. No doubt that is why folks like this have those neurological changes. This is an assessment diagnosis question, question 13. Which of the following is unlikely to be noted in Tom, a 62-year-old man with lumbar spinal stenosis? Would it be A, a report of back pain worsening with standing, B, bilateral leg numbness, C, pain improvement with flexed forward position, D, absent pedal pulses? Remember, we're going over unlikely to be found. Which one would we not find in a 62-year-old man with lumbar spinal stenosis? Of course, it's going to be option D, because what option D is saying, the absent pedal pulses, that's a vascular problem. That's peripheral arterial disease. But back pain worsening with standing, bilateral leg numbness, and that improvement discomfort with flexed forward position, those are all consistent with lumbar spinal stenosis. When taking a look at an exam question, consider risks and clinical presentation. Ben is a 48-year-old man who presents with low back pain after working on a landscaping project 3 days ago. Neuro exam is normal. Physical exam notes lumbar sacral curve straightening, as well as palpable spasm in the lumbar sacral region. You'll see quite often when you examine a person with this condition that you can actually feel the spasm throughout the lumbar sacral region. Which of the following should be performed? A, X-ray, B, CT scan, C, MRI, D, no imaging is needed. I'd be willing to bet that you're all crying out for more information about this guy. But what was described in his scenario was classic lumbar sacral strain. He just had it a few days ago, just started, and he has a normal neuro exam. Correct answer, of course, is D, no imaging is needed. I can pretty much guarantee you that he's going to ask you for a back X-ray. And the way I approach this is I'll say, the good news is you don't need a back X-ray. I pose it that way. Good news is you don't need a back X-ray. And say back X-rays really show us whether bones are broken or not. And from listening to your what's going on and how this got started with doing yard work, this point, the X-ray is not going to tell us anything. Let's get you more comfortable. So question 15, first line therapy for Ben should include, and you're going to choose two correct responses, A, methylprednisolone dose pack, i.e. Medrol dose pack, B, skeletal muscle relaxer, C, over-the-counter analgesic like ibuprofen or acetaminophen, D, opioid. Well, you know what? This gets into the whole idea of not only correct responses, but best responses. Looking at D as an option, this unfortunately, prescribing opioid therapy early on with lumbar sacral strain, which appears to what he has, is unfortunately one of the scenarios where people will occasionally get into trouble with prescription drug misuse. So first line therapy using an opioid, no. Look at option C, OTC analgesia. Yes. That's a great choice. Looking at option B, skeletal muscle relaxer. One more time, great choice. B and C are our best options. Looking at A, Medrol dose pack. Well, there are a couple of things with using a methylprednisolone dose pack. First of all, there's virtually no clinical indication around for using that modality for anything. What it does is it provides you and the patient with a very quick taper from rather high dose systemic corticosteroid to rather low dose systemic corticosteroid over a number of days. When you use systemic corticosteroids for less than 2 weeks, you don't need to taper it. You don't need to taper the dose. So there's no science behind the Medrol dose pack. The other part is when the American College of Physicians came out with their evidence-based guidelines for low back pain therapy a few years back, the most current set of guidelines we have, they advised not to use systemic corticosteroids for acute low back pain in a scenario like Ben, because there's no clinical benefit demonstrated and it still is steroids. He's a younger guy. He probably would be okay with using a burst of corticosteroid, but there's no particular clinical response seen with that. So B, skeletal muscle relaxer. C, over-the-counter analgesia. Those are the correct answers there. Question 16. You're counseling a 56-year-old woman who asks about increasing her dietary calcium intake with non-dairy foods. You counsel about adding all of the following foods that are calcium rich except A, spinach, B, tofu, C, almonds, D, red grapes. Which one of these are not rich in dietary calcium? And the correct answer is D, red grapes. If you want kind of a general rule, fruits don't have a lot of calcium in them, but almonds, tofu, and spinach all do, as well as many dairy products. But this question specifically asked non-dairy sources of calcium. Let's take a look at Table 10, defining osteoporosis. The World Health Organization has established the following definitions based on BMD measurement at the spine, hip, or forearm using a DEXA device. And looking at this, normal is BMD within 1 standard deviation of a young normal adult, so a young healthy adult. And I will say this is something we have to keep in mind with this, is that they're comparing the person to the BMD of actually a 28-year-old woman. And therefore, you would expect that an 85-year-old is going to have a lower BMD than a 28-year-old would. But this is how it's defined as normal. Now, low bone mass or osteopenia is when the BMD is between 1 and 2.5 standard deviations below that of a normal young adult. The T-score between -1 and 2.5. With osteoporosis, what is that? That's a BMD of 2.5 standard deviations or more below that of the young adult norm, or a T-score at or below 2.5. And patients in this group who have already experienced one or more fractures are deemed to have severe or established osteoporosis. That is the information you need to get you through the boards. What you'll see in the defining osteoporosis table that we've provided for you, there are additional criteria based on AACE and ACE guidelines, but I would concentrate on that BMD 2.5 standard deviations or more below that of the young, healthy adult. Note, although these definitions are necessary to establish the presence of osteoporosis, they should not be used as the sole determinant for treatment decisions. And when you're looking at Table 11, look through it as part of your study. Make sure you include this. And what this will do is guide you through osteoporosis, issues of diagnosis and intervention. Will give you an idea of who should undergo BMD testing, who should be treated, and treatment options. Those non-dairy sources of dietary calcium have been known to pop up on boards. And when you're talking about treatment options, I realize if I was teaching this course 10, 15 years ago, I would say bisphosphonates, we're done. There are a myriad of other interventions now. It's really wonderful that we have all these interventions, but I will tell you, alendronate, aka Fosamax, will likely still be the first line intervention for osteoporosis or osteoporosis prevention in the high-risk individual with established osteopenia because it is generally well tolerated and highly effective. Yes, I do appreciate that there can be GI upset with a product like alendronate, but the cost and the long-term benefit with it, that's generally where we start. And what are you going to be tested on boards? Those first-line interventions. In this next question, we want to consider risk factors in the clinical presentation of a common disease. Question 17. George is a 52-year-old man who presents with a complaint of bilateral knee pain that gets worse with activity. He denies any recent trauma or unexpected weight loss. One more time, no unexpected weight loss. Think away from the orthopedic manifestation of a systemic disease. Suspecting osteoarthritis, the NP would expect to find which of the following on examination of the knees. Would it be A, erythema, B, warmth, C, crepitus upon extension, D, swelling? General rule with OA, there's no warmth, there's no swelling, there's no redness. Best answer here is C, crepitus upon extension. Question 18. Which of the following would be the most appropriate treatment option for George? A, topical corticosteroids, B, quadriceps strengthening exercises, C, chondroitin and glucosamine supplements, D, hyaluronic acid intraarticular injection. What we have to do now is go back to best evidence. And the answer here would be option B, quadriceps strengthening exercise. When looking at the other choices, chondroitin and glucosamine, I know in some circles you'll hear this advocated as helpful in OA. The orthopedic surgery group says no, it's not helpful, and that the intraarticular injections of hyaluronic acid may be in certain situations, but we always want to go with what's first line. Why is quadriceps strengthening exercises important? Because strengthening the quads helps stabilize the knees. And in your handout, there is information in Table 12, assessment, diagnosis, and treatment of OA of the knee. This is an evaluation diagnostic question. Question 19, match each of the following patient findings with the associated disease state, and an item can be used more than once. Just to reiterate, you're not going to get exam questions in this exact format on the boards, but what this allows us to do is reinforce the differential diagnosis process when you've got a lot of different diseases where there could be overlap in how they present. Identification and findings in these different disease states. A 44-year-old woman with a normocytic, normochromic, non-evolving anemia, i.e. RDW is normal. So out of those three disease states I just rattled off, lupus, RA, OA, which one of those, and it can be more than one, would you expect to find anemia of chronic disease? And that's going to be rheumatoid arthritis and systemic lupus. A 34-year-old woman with an elevated C-reactive protein. One more time, you're going to go with RA and lupus because those are systemic illnesses with inflammatory component to them. The other part you'll notice on these, both of the cases are younger women. And RA and lupus are far more common in younger women than they are in males. Now, one point to keep in mind, the elevated C-reactive protein or SED rate, whatever it is, when the inflammatory markers are up, generally that's when you're seeing somebody whose disease has not yet been treated or was previously on treatment, came off of it, is flaring again, something along those lines. Once RA and lupus, the disease states are under control, the C-reactive protein, the SED rate will normalize, and the anemia of chronic disease will resolve. A 57-year-old man with a BMI of 39 and knee pain associated with joint space narrowing on X-ray. What would that be? That's the classic presentation of osteoarthritis. What do you have here for risk factors? Higher BMI and an adult close to 60 years old. A 51-year-old woman with morning stiffness in her hands and a positive ANA antibody titer. What could that be? And that's going to be rheumatoid arthritis. Less commonly is there a positive ANA than in lupus, or it could be systemic lupus. In lupus, the ANA is almost always positive. In RA, it's maybe about 60% of the time it will be positive. Keep in mind with rheumatoid arthritis, what one of our therapeutic goals is to avoid having patients whose hands or any of their joints end up looking like this. You can look at this x-ray and say, well, what did that person do? Have their hands bent like that when they were having the film shot? And no, that's actually a person with tremendous joint destruction and permanent contractures in the joints because of untreated RA. Why was it untreated? This is a very old x-ray, and this was before we had a lot of intervention for rheumatoid arthritis. Osteoarthritis, is it a systemic disease? No, it is a localized disease. Does it have a big systemic inflammatory component? No, again. What are you going to notice in osteoarthritis? What you will notice on x-ray is joint space narrowing, that the normal joint space is no longer preserved and there is joint space narrowing. That's one of the characteristics of OA. This is an assessment diagnostic question, question 20. Mrs. Garcia is a 78-year-old woman who presents with the chief complaint of a 1-year history of progressively increasing aches limited to her hands and fingers, particularly after doing yard work. Otherwise, she denies musculoskeletal problems. What is she telling you? Here's my problem. It's my hands and only my hands. Physical exam reveals bilateral Herbigans and Bouchard's nodes. Where is the location of the Herbigin nodes? Is it location A, B, or C? And as we look at this image here, it is location A. Location of the Bouchard's nodes, that's going to be location B, as it is pointed out here on this image. What you want to do now with this next question is consider age, slower development, and symptom triggers. What is she telling you? My hands hurt more after I've done something like yard work. Picture what people need to put in their hands to do yard work. A rake, a shovel, something like that. Question 21, Mrs. Garcia's most likely diagnosis is A, systemic lupus, B, rheumatoid arthritis, C, osteoarthritis, or D, reactive arthritis. And of course, the correct answer here is osteoarthritis. Common diseases occur commonly in a woman of her age with hand aches only as her orthopedic complaint. You want to think OA and not a systemic disease like lupus or rheumatoid arthritis. By the way, reactive arthritis is a type of arthritis that can sometimes be seen with an infection. There are a variety of different infectious agents that could trigger reactive arthritis. Wouldn't even give that a thought with this case because no systemic illness is mentioned. What you want to do whenever you see a person with an orthopedic issue is always ensure the physical exam is consistent with the history. I've mentioned this before in the program. Anytime a person has an injury, what you want to do is make sure the exam is consistent with the history. Question 22. A 21-year-old man presents about 48 hours after a non-syncopal fall on an outstretched hand, foosh injury, during a pickup soccer game with friends. He relates that since the fall, he's had pain in the anatomic snuff box that worsens with hand grip. Where is the anatomic snuff box? You can see it here in this image. Physical exam reveals tenderness in the anatomical snuff box with minimal swelling without additional abnormalities. You might say, this seems a little odd, and would this person come into primary care? The answer is one, it's not that odd. Two, this is not that uncommon to come into primary care. Let's read the entire question. He adds that he visited a local urgent care center immediately after the fall and reports an x ray done there failed to reveal any, quote, broken bones, close quote. He was told to apply ice to the area. One more time, what you need to do is realize he fell on the outstretched hands. He's got pain in that anatomic snuff box, and it looks like it wasn't broken, but is there anything that we need to keep in mind? And choosing two that apply, your next best action is to A, apply a spica thumb splint, B, refer to orthopedics, C, provide a sling to the affected limb, D, refer to physical therapy, E, advise wearing protective gloves while playing soccer. Well, let's take a look at the bottom one, E, protective gloves while playing soccer. That might help avoid a scrape injury, an abrasion, something like that, but it wouldn't have made any difference on this. D, refer to physical therapy. That could be a helpful piece of advice, but let's make sure that we have a really good diagnosis here. C, provide a sling to the affected limb. Keep in mind in primary care, a sling is generally kind of a stopgap measure we do to keep a hand or a forearm supported until we're able to do something else. B, refer to orthopedics. Yes, that's going to be one of the correct answers. And what's the other is apply a spica thumb splint. What do you want to do here? You want to refer to orthopedics. I've said this a number of times. I'll say it again. When do we refer people to specialists? When the specialists can do something that we cannot. This is a hand. You don't mess around with hand injuries. His injury is consistent with his history. I'm not worried that something more nefarious happened to him. I bet he was messing around playing soccer with some friends and he slipped and put his hand out, which is a natural reaction, and he landed on it. The bones in the hands are pretty delicate. The spica thumb splint will be very helpful for stabilizing what's going on. And what are we looking at here? We're thinking that probably what he has is a scaphoid fracture. And what's the mechanism of a scaphoid fracture? It's Fuchs and extension injury. The palmar branch of the radial artery supplies blood to the scaphoid's distal pole, then the proximal pole. The blood supply can be disrupted by fracture with a risk of non-union and avascular necrosis. Therefore, you want ortho referral for expert opinion. How does it present? Well, one of the things I want you to remember here is what are the bones within the wrists and the hand. And this is a mnemonic that some people like to remember. All of these bones here. Scared lovers try positions they can't handle. And looking at A, that's the location of the scaphoid bone. And then looking at 1, 2, and 3. 1 is the location of the radius, 2, the ulna, and 3, the metacarpus. Clinical presentation, there'll be pain in that anatomic snuff box, decreased grip strength, decreased hand strength. You want to get the standard x-rays plus a scaphoid view, can often miss this fracture. And that is one reason if the person had a Fuchs injury, the initial x-rays look negative, it's helpful to repeat them in 7 to 10 days. You might say to yourself, well, I've heard that happen before, that people had x-rays in the ER or walk-in center or whatever. They get seen back in a week, x-rays are repeated, and lo and behold, they find a fracture. Well, X-rays aren't perfect. Sometimes fractures are missed. And what sometimes will show up is a number of days out, particularly if there's some healing going on in the bone. If it was a non-displaced fracture, that there's bone union, that you can actually see some healing going on in that, and that shows up on X-ray. And so that's why repeating the radiographs on somebody whose hand still hurts 7 to 10 days out, even with negative X-rays, consider that. And that CT, MRI, and bone scan can sometimes be done if there are classic findings, but the X-ray is within normal limits. Initial treatment, even if the initial radiographs are negative, a thumb spica splint, analgesia, and orthopedic referral. And you'll see where the red is pointed here on the X-ray, there's that fracture. Keep in mind, when in doubt with a hand injury, a wrist injury, it's an early orthopedic referral, not a later orthopedic referral. In table 14, what are we going to do? We're going to now look at ankle sprains and grading 1, 2, and 3 sprains. And we'll take a look at intervention in ankle sprains. You could see table for additional details. One more time, you might say, well, if somebody has an ankle sprain, wouldn't they just go to the emergency room or urgent care? Actually, people come in all the time to primary care with ankle sprains. What's the etiology or mechanism of injury? With a grade 1 sprain, it's mild stretching of the ligament with microscopic tears in the ligament, but there's no evidence of joint instability on exam. The person could still bear weight, little bit of discomfort. A grade 2 sprain is an incomplete tear of the ligament, mild to moderate joint instability, decreased range of motion. Weight bearing and ambulation are actually quite uncomfortable, mild to moderate pain, swelling, tenderness, and ecchymosis. So grade 1, you're probably not going to get any ecchymosis. You're going to get minimal swelling. Grade 2, sometimes folks come in, the ankle is starting to turn purple, there's swelling, and then you go to range the ankle and you can feel that the joint is relatively unstable and the person is really unable to bear weight. Grade 3 strain. Now, grade 3 strains are quite uncommon. So I don't want you to forget that these exist, but focus your study on grade 1, grade 2. Complete tear of the ligament, pain, swelling, tenderness, ecchymosis, loss of function and movement, and the person is unable to bear weight and ambulate. The ankle is kind of flopping back and forth. What do you want to do with all ankle sprains? Rice, rest, ice, compression, elevation, crutches until able to walk a normal gait. That would be more like grade 2 sprain. Grade 1 sprain, most of the time, just rice alone will do the trick. Analgesia, physical therapy, and consider ortho referral, definitely for a grade 3 ankle sprain. Because the differential diagnosis includes fracture, dislocation, subluxation, tendon rupture, and a few others. With grade 1, do not immobilize. Grade 2, immobilize with an air cast or a splint for a few weeks. Grade 3, it's going to have to be a cast, splint, or boot. Grade 3, definitely managed with orthopedic consultation. You do not want to miss an occult fracture. Now, what with grade 1, you don't need to immobilize, but generally put some kind of a compression device on it, like even a compression bandage, something along those lines. Very helpful for managing the swelling. Question 23. This is going to help you with your differential diagnosis. A grade 2 ankle sprain is best described as A, minor swelling with minimal joint instability, B, moderate joint instability without swelling or ecchymosis, full range of motion. C, mild to moderate joint instability, decreased range of motion. D, complete ankle instability, significant swelling, and moderate to severe ecchymosis. Remember back to what I said a few moments ago about the different grades of ankle sprain. And obviously, C is the only correct answer, mild to moderate joint instability with decreased range of motion. Keep in mind the mechanism of injury with an ankle sprain, and that you know some of the key connections throughout the ankle. Those tissues have been damaged, and that will help you conceptualize and remember that you're going to get that decreased range of motion. Question 24, a person with a third-degree ankle sprain presents with A, minor swelling and minimal joint instability, B, moderate joint instability without swelling or ecchymosis, C, moderate swelling, mild to moderate ecchymosis, and moderate joint instability, D, complete ankle instability, significant swelling, and moderate to severe ecchymosis. And that, of course, is going to be D. Complete ankle instability, severe swelling, and moderate to severe ecchymosis. Grade 3 ankle sprains can be very impressive. Now, reflecting on grade 1, you're going to have that minimum swelling, minimum ecchymosis, the ankle joint still going to be pretty stable. And it's not to say that it's any fun to have a grade 1 ankle sprain, but it's not as devastating as grade 2 and particularly grade 3. Question 25. Patients with a grade 2 ankle sprain should be advised that recovery is likely going to require which of the following? And you want to choose 2 that apply. A, application of an air cast or splint. B, 4 to 6 weeks of recovery. C, surgical intervention. D, many months of non-weight bearing. Well, I suspect if you simply thought this through, you could come up with the answers, and it's A and B. Application of an air cast or a splint to immobilize the joint, give it better stability, and about 4 to 6 weeks of recovery. It is slow to get over even a grade 1 ankle sprain. It's tough to recover from them. Quite often you'll hear people in orthopedics say, oh, this person had a grade 2 ankle sprain. They would have gotten better quicker had they just broken the ankle. And there is something to say to that because the bones tend to heal up quicker than the soft tissues do. With a grade 2, surgical intervention is not required. And how long for non-weight bearing? Until it doesn't hurt to walk anymore. That's generally about 4 to 6 weeks of recovery, maybe even sooner. Remember, for important additional study resources available through your Fitzgerald Health online learning portal, will include CMP1, neuro testing for cervical vertebral problems, then the FHEA newsletter article on evaluating and treating vitamin D deficiency. You can find that at the link that you've been provided with in your handout. It's interesting. I hopped on the treat vitamin D bandwagon a number of years ago. And in all my many, many years of practice, I have seldom seen a single relatively easy intervention do so much good for so many people. And please read that through. I honestly am not sure whether there'll be any questions on vitamin D deficiency on your boards, but this is something to keep in mind because new information crops up on the boards on a regular basis. Vitamin D deficiency, it's been a lot in the professional and the lay literature recently. And once we hear something like that for a few years, then it tends to crop up on the boards. And for a helpful guide to conducting the orthophysical assessment, Monica Tambasco and Louise McDevitt put together the orthopedic physical assessment cue cards, can be very helpful in helping you with that.